Hello everyone. Today we'll learn hyperthyroidism. I'm Dr. Tang. First, we'll learn the definition. Hyperthyroidism is an imbalance of metabolism caused by overproduction of thyroid hormone. The cause is increased secretion of thyroid hormone. There are various causes. First is Graves' disease is 85%. Autonomous toxic adenomas of the thyroid. Plummer's disease or toxic multinodular goiter. Judd-Bristol disease, LDAM-induced TH, and functioning thyroid carcinoma. The TSH hypersecretion by the pituitary and the tumor ovarian and the subacute thyroiditis and Hashimoto's thyroiditis and the thyrotoxicosis factor and the carcinoma accompanying thyrotoxicosis. The ratio of female and male is 4:1. It tends to affect males more severely. The incidence is 20 to 40 years old group. The clinical manifestation. The first is goiter. The thyroid can be palpated for asymmetry in size. It may enlarge 3 to 4 times to its normal size. Osmopathy and the increased metabolism rate and the increased function of sympathetic nerve and the cardiovascular alteration. This is the exophthalmos, and this is the normal thyroid. This is the diffused goiter, and this is the enlarged thyroid. This is a hyperthyroidism caused by thyroid adenoma, and this is the hyperfunctioning thyroid. As a result of increased thyroid hormone production, the client has an increased metabolic rate. Weight loss despite increased appetite, fatigue, poor tolerance to heat, and profuse perspiration, menstrual irregularity. The common clinical manifestation nervous system is nervous, restlessness, irritability, and difficulty concentrating, emotional liability, mood swings, personality changes, fine tremors of the fingers and thumb, shaky handwriting, and clumsiness, trouble in claim styles, or dyspnea, possibility at rest. Cardiovascular is palpitation, tachycardia, and atrial fibrillation, widened pulse pressure. Tachycardia is more than 116 and down to 80 during sleep. Pulse pressure is widened. Gastrointestinal increased appetite, hyperdefecation and diarrhea, hematologic system, moderate neutropenia, mild anemia, and others is oligomenorrhea. The skin is warm and most characteristic same color. The hair is thin and soft, with premature gray and increased hair loss. The layers appear fragile with distal layer separation from the layer bed. There can be muscle weakness and atrophy, paralysis, and the expected clinical manifestation is T3 toxicosis, initial phases or a relapse of Graves' disease, the T4 toxicosis, and epistatic hyperthyroidism, serotoxic crisis, and serotoxic myopathy, hypokalemic, periodic myelolysis, and hyperthyroidism in pregnancy. Cardiac complications is atrial fibrillation. Diagnostic test. The first is TSH, the T3 and T4 radioactive iodine uptake, and thyroid scan and measuration of basic metabolism rate. The first is TSH, the thyroid stimulating hormone. Normal TSH reflects an in-thyroid state. Hyperthyroidism, the TSH is low or absent. In mild forms of hyperthyroidism, is slightly abnormal. The basic metabolism rate. Conditions: early in the morning, empty stomach, at the time of rest. The basic metabolism rate is plus rate, add plus pressure, and then subtract 111. The normal is plus or minus 10%. The slightly abnormal is plus 20 to 30%. Moderately abnormal is plus 30 to 60%. Seriously abnormal is more than plus 60%. The thyroid scans are helpful in determining location, size, shape, and anatomic function of the thyroid gland. The radioactive iodine uptake. The normal is 3 hours is 5 to 25%. 24 hours is 20 to 45%. Peak at 24% hours. Hyperthyroidism is total intake increases The peak is forward. The differential diagnosis. The other causes of serotoxicosis and anxiety, neurosis or mania, some state of hypermetabolism without serotoxicosis, severe anemia, leukemia, cardiac disease, atrial fibrillation, and angina pheochromocytoma, and other causes of ophthalmoplegia, myasthenia gravis, and exophthalmosis, and others is COPD, DM, cirrhosis of the liver. The diagnosis. According to the symptoms, signs, and laboratory examination, will diagnose hyperthyroidism. Will the treatment. Anti-thyroid drugs, ceramides, radioactive iodine, and the third is thyroid surgery. Individualized and depend on the age and the general state of health, the size of the goiter, and the ability to obtain follow-up care. Ceramides. Common use. First is mercilazole. The second is propylcerolidine. Dosage and duration of ceramides. Adverse action is a granular cytosis, rash, including hives and hepatitis with PTU, aspergir, meningitis, and neuritis. Cholestasis with MMI. The fourth is relapse. There are other medicine, aldehyde agent, and beta-blocking agent, propranolol, and the third is thyroid hormone. The second treatment is radioactive iodine. Indication: contraindication. Female in pregnancy or the person less than 25 years. Complication is hypothyroidism. The incidence is significant during the first year or two after treatment and continues to increase at a rate of 5% a year thereafter. Hypothyroidism at 5 years is 30%, and at 10 years is 40%. The second treatment is surgical indications. A very large goiter or a multilodular goiter with relatively low radioactive iodine uptake. Malignant thyroid nodule. Psychologically or mentally incompetent patient. Partial or complete thyroidectomy may be carried out as primary treatment. The type and extent of the surgery depend on the diagnosis, goal of surgery, and prognosis. If a partial thyroidectomy is done, the remaining thyroid tissue should provide a adequate amount of thyroid hormones. If a complete thyroidectomy is done, the client will require thyroid hormone replacement for a lifetime. Then will learn the thyroid crisis. The reason is insufficient preoperative preparation, a release of large amount of thyroid hormone is rare. The outcome is can lead to cardiac, hepatic, or renal failure. The stressful factors, such as surgery, infection, or tremor, pregnancy. Gastrointestinal is diarrhea, abdominal pain. Neurological is psychosis, somnolence, and coma. Cardiovascular is edema, chest pain, dyspnea, and palpitations. Time of occurrence: the first 12 hours postoperative. The clinical manifestation: the first is tachycardia, more than 116, and the second is temperature, more than 30 Lem, sometimes more than 41. The third is exaggeratory symptoms of hyperthyroidism. The fourth is disturbance of a major system. Fatness: the client may develop congestive heart failure and die. Preventions: the key is to do the preoperative preparation sufficiently and perform the surgery until the BMR becomes normal. The medical management: the physician must be informed immediately, transfer the patient to the intensive care for closer monitoring. LDM is administered to decrease the output of thyroid hormone. Take LDM solution 3 ml orally, or put 10% LDM sodium 5 ml into 10% glucose and give intravenous injection to the patient. 200 to 400 mg hydrocortisone is prescribed to treat shock or adrenal insufficiency, reduce body temperature and heart rate, and to prevent vascular collapse. A large amount of glucose are needed. Oxygen therapy. Humidified oxygen is administered to improve tissue oxygenation and meet the high metabolic demand, cardiac problems, atrial fibrillation, and congestive heart failure. Symphylatic agents may be administered, such as propranolol. And it's all. Thank you.